Keith Fox, and here we are at the American College of Cardiology, and we're at the wrap-up of day one. And I'm delighted to have with me Dan Atar from Oslo and Chris Cannon from Boston, two key experts from either side of the Atlantic. So I want your insights into some of the really important studies of today. And we're going to start with the Sur-TAVI study. So the Sur-TAVI study is patients with severe aortic stenosis, intermediate risk, being randomized to surgery or to TAVI, and looking at the outcomes, hard outcomes. And it set out to be a non-inferiority trial. It met its objectives. So my question to you both is, you have an 85-year-old relative who comes to you and says, look, I know, the heart team has told me I'm eligible for either, but I believe you and I want to know, what should I have? Chris, what should your aunt have?
Well, I would, personally, I'd ask the heart team what they're
okay.
And that's a wonderful resource.
The heart team's good, yeah.
It's a wonderful resource to have this decision-making done together, and it's a real change from the usual...
Because it says what's in the interests of the patient.
Yeah. And the data are very interesting to see that the hard outcomes were similar, but then stroke is less with the TAVI than surgery, and many of the other complications of renal failure and AFib and hospital stay. And
hospital stay was less, and there's going to be health economic implications as well.
Yeah, so the TAVI, even in this lower risk group, officially intermediate risk, although they pointed out that their risks were actually pretty low.
Yes.
In the current era, so it's a good option.
A good option.
Yeah.
Now, 2 years, is that enough?
Of course.
Durability?
Of course, it's preliminary, but we must see that, as you mentioned, the stroke rate has a big impact for this type of population. Mm-hmm. This is what we fear. Mm-hmm. Patients may survive, but suffering a stroke is really devastating. So that was very reassuring in this.
The stroke rates in the recent TAVI studies have been very much lower compared to some of the very early studies.
Yes. So that is pointing to a reassuring positioning of TAVI. Okay,
so this is a key study. It's setting a marker that TAVI is a key option, provided everything else in the terms of the heart team says it's similar. Are our surgical colleagues going to be out of work?
Well, I think they are partly involved even in TAVI, at least in our place.
Yeah, some of the evidence in our country and others, and I think it's the same in the US, is that the surgical operations have continued. It's that the unmet need has expanded and been filled by some of the TAVI. Yeah. So I want to turn to a second area, which is LDL reduction with, for example, PCSK9. So, we've heard some really interesting studies today with the PCSK9 inhibitors, either the fully humanized or the human monoclonal antibody. We know from the studies that, Dan, you've talked about the fact that the humanized mouse antibody, that program has stopped. And really there was antibodies developed over the course of time.
Exactly. We must realize that there is an issue with immunogenicity when we look at therapies that are antibody-based. Yeah. So it appears that there is a gradient, a biological gradient, as whether you're utilizing a, as you say, fully monoclonal human antibody or a humanized antibody, although it may only contain 3% of the entire sequence from a murine original signal, it seems to be enough to cause trouble.
Okay, so Chris, the key take-home messages from the Fourier study.
Well, this was to see and found a clinical benefit in using a PCSK9 inhibitor in preventing cardiovascular events. And so the big events reduced were MI and stroke, but the endpoint of cardiovascular death, MI, stroke significantly reduced. And this was done at LDLs that went from 90 to 30 on average, and even the different quartiles looking from 70 to 20 there's a benefit.
Yeah.
And so one can see benefit really down to these super low levels.
So this is sort of perinatal LDL.
Yeah. And real question has been, do you really need to be that low? And today we saw that there is benefit getting that low.
Yeah.
These are costly therapies, and so we'll want to make sure and be responsible and get them to people who really have used all the oral therapies and still have too high an LDL. But a wonderful day to reaffirm the clinical outcome benefit in reducing LDL.
And this wasn't jumping in with a PCSK9 first. This was on top of statin therapy.
Right, so 2/3 were on high-dose statin.
Were on high-dose statin.
And some on ezetimibe, and maximally tolerated was the requirement.
Yeah.
So, they've tried most of what you would want and then got a nice benefit from
Now, Chris,
that.
you're a trial expert. And if we look at the composite endpoint, most of the things stacked up, apart from cardiovascular death. And if we look at the other trials of intensive lipid lowering, cardiovascular death doesn't seem to be impacted on.
Yeah, no, it's
Why?
true. And even dating back to all 5 of the intensive statin therapy didn't significantly reduce cardiovascular death. One of the thoughts is that our therapies are pretty good, and so it's hard to impact the cardiovascular death. There are also many causes of cardiovascular death that may not be directly related to the lipid and atherol modification. So that has been seen. It's really going from placebo onto statin that you see the mortality benefit. But anything beyond that, it's just benefits in MI, stroke, and need for revascularization.
Now, the absolute difference is 1.5%. And in treating 13,500 individuals for 22 months, my rough calculation is the NNT is about 69.
For over 2 years.
Over 2 years.
So the key factor here is that it was a median of 2.2 years. All the other trials are 5. So the NNT numbers we have in our head are based on 5 years of treatment.
Based on 5 years.
So we need to do the extrapolation to what would be an absolute reduction at 5 years to be able to compare.
And in fact, there is some evidence that the curves were separating more over time, which is really quite encouraging. Last thing in the last couple of minutes, the Tismani tribe from Borneo, hardly any coronary disease, the lowest in the world based on the CT scans, but the LDLs were about 90.
And that is surprising, because we would of course expect that you have really a tribal native population that really is absolutely low in LDL. They were not. It just tells us how multifactorial this disease entity is.
They were very active, they ate a lot of vegetables, a lot of fish. Maybe there's a message for us.
It's not fish and chips.
It's not fish and chips.
just the fish.
It's just the fish, the oily fish and the exercise. So here we are at the end of the day. Some really important studies, things that will impact on practice. And if you were to judge 5 years from now, are we going to be using interference RNA or PCSK9s as your take-home message? What's your guess?
They looked very good. It's at a moderate-sized study that the LDL reduction looked as what we would hope, a little bit less than an antibody, but it's an effective therapy. It may be more cost-effective. We'll have to see.
A couple of injections for 6 months.
I think many people will be getting PCSK9-based therapy in some form because this really does open an era of getting to really low levels with benefit.
So what's really intriguing is that PCSK9 is the topic of the day and will remain, I think, for the entire Congress. But as we heard, there is probably a variety of approaches to it. And it's very interesting to think that maybe the antibody-based approach is not the one that will give us the best solution in the future.
Terrific. Well, thank you both very much. These really important insights into an exciting first day at the ACC Congress.
Thank you.
Thank you.